Well, hello, everybody. Good evening and welcome to the Institute of Health and Social Care Management and the latest in our PowerHour series. Tonight, we're talking about something very current, very topical, and increasingly very important in terms of driving efficiencies and values through health and social care. It's all about how to do virtual wards. And we have an absolutely stellar lineup of panelists, chaired, of course, by our only Roy Lilley. I'll just quickly introduce Professor Alison Leary, Elaine Strachan-Hall, Steph Lawrence, Alexandra Evans, and Dr. Elaine Maxwell. Without further ado, Roy, I'm going to hand over to you so they can all make quick introductions. Thank you.
Good, John, thanks very much and welcome everybody. It's lovely to see you all. If you're watching this as a recording, well, I'm afraid you won't be able to ask any questions, but if you're watching us live, there's a chat box, so you can put questions in the chat box and I'll try and pick them up on the way, or we will try and leave a little bit of time at the end to address any questions you've got. With me tonight, we've got a stellar lineup, as John has said, and I'll ask them to introduce themselves in more detail in a moment. But I have to say that I come at this topic as someone who saw virtual wards, and you know, any of you that've seen my stuff and know you know what I'm interested in, it's like it's IT, it's terrific, it's got to be good. I'm really really revved up, and I thought this is going to be terrific. And then, of course, the more I got involved with it, and then I spoke to Alison, and I thought, you know what, I'm not so sure this is such a good idea. So I don't know what I believe anymore, but I hope we'll find out on this journey tonight. So let me just do a quick whiz around the panel. I'm going to ask them to introduce themselves, tell us a little bit about themselves, and then we'll go from there. So can we start with you, Dr. Elaine Maxwell? Just say hi, good evening, and tell us a bit about yourself.
Hi, thanks for having me. So my background is nursing. I've been an executive director of nursing in trusts. I've been a non-executive director in trusts, but for the last 10, 15 years, I've been an academic, most recently working for the IHSCM in the Dissemination Centre, looking at the evidence and how that affects practice.
Okay, thank you. Alex Evans, perhaps you go next, please.
Yeah.
Lined up on my screen.
That's absolutely fine, Roy. Thank you very much. And I'm really delighted to be here this evening. I've also come through the nursing route. I'm a trained nurse. I have worked mainly in the commercial sector, actually, nearly all of my career, and in director of nursing roles and director of quality and governance in nursing roles as well. And I'm currently a candidate on the professional doctorate in nursing at Oxford Brookes.
Thanks, Alex. Now, Elaine Strachan-Hall, good evening. Lovely to see you.
Hi, lovely to be here. So I'm currently working with organisations, helping them with their operational excellence. Also have a background as a chief nurse, both in the community, but predominantly the acute sector, but also worked with virtual wards in the private sector, and also currently undertaking my doctorate in nursing with Alex and working as a commissioning nurse.
Great, thanks very much. Steph Lawrence, you're next. I think you just need to do your microphone. Yes, well done. Thanks, Steph.
Thank you. My name's Steph Lawrence. I'm the Director of Nursing at Leeds Community Healthcare. I'm a district nurse and advanced clinical practitioner by background. I set up and ran a virtual ward back in 2008. And we have virtual wards in the organisation I work in now as well.
Right, so, and last but by no means least, our great friend and supporter, Dr. Alison Leary. How are you doing, Alison?
I'm great, thanks, Roy, and thanks for inviting me. I'm Alison Leary. I'm a Professor of Healthcare and Workforce Modelling at London South Bank and the Director of the ICNO, which is the research part of the Queen's Nursing Institute. I'm also have personal experience of virtual wards last year.
Okay, right. Well, where do I start? I mean, just throw the dart at the screen, see where it lands. I tell you what I'm going to do. I'm going to go to Steph first, because she's sort of done one, as it were, and let's just see, you know, what you think. I mean, it seems to me the technology is fine, but unless you've got some really smart people running the whole thing, it's a big risk. Discuss. Let's go from there.
So yes, I would agree completely with that. I would start by saying that I think most nursing that goes on in the community is the equivalent of a virtual ward. So what district nurses do every single day is keep people out of hospital and keep them safe and well at home by doing exactly what you say, being skilled at the job that they do, by doing good nursing assessment and making sure that the right care is delivered to those patients. I think virtual wards, whilst it's a concept, I think it can be done well, but it does need absolutely the right staff. So I think technology can help support it, but it can't do the job.
Okay, what we're going to try and do tonight is we're going to try and produce a paper at the end of tonight that we can circulate to our members. And we want to do a sort of the Dummy's Guide to Virtual Wards with like 10 things that are really important. And so, I mean, what I get out of that, Steph, is that they're not a substitute for a hospital ward. They're a different thing.
Yes.
Is that right? Yeah.
I think people can have the choice, but it has to be safe when you're delivering care in somebody's own home, because you don't have all the equipment and the technology that you have around you in a hospital.
Yeah. Elaine, you wanted to come in.
Yes,
Elaine Maxwell, sorry.
Yeah, there is quite a lot of research evidence on this. And it's clear that there isn't a one-size-fits-all. This term virtual ward is being used to encompass a whole load of things. So it originally comes from the Croydon pilot, and this was a result of the finding that Kaiser Permanente had less age-adjusted admissions than the NHS. And that was thought to be because of better integrated care in the community. So virtual wards were very much about interdisciplinary decision-making. So that's one model. There's the case management model that district nurses have done. That's a different model. There is this whole thing that's come up with COVID about remote monitoring of people, but that's specifically about remote monitoring of 1 or 2 symptoms. It's very different from integrated care for people with multiple long-term conditions. And then there's a fourth model, which is the post-discharge or transitional care model. And I think one of the challenges, as we always have in the NHS, is we're talking about something as though it was one unified thing. And the reason it doesn't work is because we're not separating out the different client groups.
Right, let me just stop you there, Elaine. Sorry, just to cut across, you don't think me rude. There's a bit of a delay and it's kind of awkward to butt in. What the guidance has said, or certainly what the department has said about this sort of NHS England, is that they want every hospital to have 500 beds managed in this way.
Well, they've said they want 40 to 50 virtual beds per 100,000 population. They haven't actually specified where they are or how they're configured. And you could actually divide that up and say, we're going to have some for the frequent flyers with long-term conditions, and we're going to have some for the transitional discharge care.
Right. So I mean, what we've learned from that already is that there are all kinds of different virtual wards in the same way there are all kinds of different wards in hospital. Alison, what's been come to you next, if I may? What's your you've had some recent experience of this. What have you found?
Yeah, so a personal experience has been the sort of post-COVID model with various relatives and friends. And it's been a very kind of superficial model. So it isn't the sort of model that Steph runs. It's sort of a couple of phone calls over a few weeks to see how people are doing. When people probably did need actual nursing care. So, and there seems to be a confounding of nursing care and sort of domiciliary care being the same thing, which it isn't. If people are acutely unwell at home, they need actual nursing care. But the reason it came to my attention is because we're modelling QNI workforce standards, which actually are out tomorrow. As you know, the district nursing services in this country are under a huge amount of pressure. And what we found in that data is that district nurses and community nursing teams are being asked to look after more and more of these services, particularly out of hours. So, for example, the technology-enabled care home, where the alarms go off on the app and somebody's got to go and see that person, and it falls to the district nurse to go and do that. So the concern, I think, for us is more about implementation. It's not that these different models don't serve different purposes. It's just there seems to be a one-size-fits-all you know, application implementation without really thinking through, and absolutely no workforce impact assessments whatsoever. I've not seen one.
No, okay, let me come to Elaine Strachan-Hall. What's your view, Elaine?
Thank you. And I've been part of running virtual wards as a provider to the NHS. And Elaine's quite right. There is a plethora of how we describe that and what it means.
Okay, can I just stop you there? When you say as a provider to the NHS, yeah. Is this a company?
So as a company, as part of commissioned by the NHS to provide a virtual ward, and
kind of an outreach or in reach.
But it was under the auspice of every trust hospital that provide that. We were the provider of the staff, the technology. And what made it work was a really sound workforce model. Alison's absolutely right. The workforce is the key model. And whilst the location is different, the staffing is absolutely critical. And the other thing I just pitch that we found really important is the leadership. The really sound leadership, and that must be your experience, Steph, that it's the district nurse or the leadership of someone who's used to deteriorating patients and well patients, but more importantly, is really used to community environment. It's very different from a hospital environment. So that leadership was one of the success factors.
Okay, so leadership is another issue, John, and the type of customer, if I can put it like that. Alex, you wanted to come in.
I did, yeah, and thank you very much, Roy, and everybody. I agree with what you're saying, and having experience delivering virtual wards over the last 6 years or so through a a private firm under a contract to the NHS, I think there are a number of things that we need to consider. And having looked at this, the report and the aspiration, I think from an NHS acute trust level, it's a transformational leadership area. It can't be just something that's bolted on. And I think Alison mentioned, sort of trying to interpret it yourselves. So it has to be transformational in terms of its approach, and everybody buying into it and agreeing, what is going to be achieved by the virtual ward process.
Mary Hawkin just put in the chat box. Mary, it's nice to see you. I'm pleased you're with us tonight. She said, Elaine said, and I think she meant Elaine Maxwell, virtual wards in the private sector, are there any? If so, what do they cover and how do they function? Do they depend on patients being IT connected? Well, I mean, I think we've covered the fact that, yes, these are private companies in the same way that domiciliary care is private companies. To what extent, I mean, this whole strand of policy is sort of underpinned by a belief that the IT is going to make it safer, make it more thorough, make it better, make it plugged in and lights will flash. I mean, what experience have we got? Perhaps if I could come back to you, Alex, and then to Elaine, because you've done this. I mean, have you? To what extent have you depended on the IT, and what do you do in people's homes? I mean, my mum, when she was alive, God bless her, she had an iPad and she was on Wi-Fi, but I'm not sure that what else there could have been that would have been safe. Give us
I think it's really important to recognise that the IT element is only a very small factor in all of this. And
so it's not about the IT.
It's not so much about the IT, it's more about the clinical element of it and the care that is provided to patients when they go into their home for either a recovery at home purpose or a early supported discharge or whatever, continuing their care that's been established in the hospital. And I think that's really important, that it's nursing care, it's also physiotherapy, occupational therapy, pharmacy. The whole element of care needs to be considered in this, and not just thinking about the IT. Can play an important part. It's not even always necessary. Going back 6 years ago when I first worked in this area, IT played a very small part, but there was some wraparound care available at the end of a telephone.
Yeah, up in Scotland, I remember, I'll come to you, Elaine Maxwell, in a second. I remember going up to an IT conference in Scotland where they had this kind of approach in the remote parts of Scotland, where they actually had a dedicated TV channel. There was before the sort of Wi-Fi thing, and that sort of worked quite well. Let me just go to Elaine Strachan-Hall, and I'll come to the other Elaine. I'd like to just sort of deal with the IT element of this, because a big part of what the government is doing, the big push now with moving NHSX back into NHSE and NHS Digital, sort of having a very foggy future. To what extent did what you did rely on IT?
The IT was important for the record keeping and for access to protocols, but as Alex says, it wasn't the critical element. But having access to IT was important. But I think as we go forward, that the IT technology, the wearable technology and the opportunities will be greater, but we mustn't forget that someone needs to operate those, and someone needs to make sure they work, and someone needs to respond to whatever that IT tells us. And you made the point that while some of the COVID virtual wards were very much about individuals using an app to put their details in, the models I've worked in is where we have a more dependent patient group, where actually it's the staff that are using the IT and helping that to enable and assist their work to better serve that patient. So I think whilst it was small for us at the time, I think this is an area of development, but we mustn't forget at any point every time we use technology, it has to work, it has to be robust, and we have to have a way of integrating it with human provided care and assessment and evaluation.
Yes, and linking it into patient records as well. If you're going to do pulse oximeter readings, you need to record that. How the hell do you do that? Elaine, I know you wanted to come in earlier. Let me just ask you a question, and then please follow on with the point you wanted to make. When I read the Kaiser Permanente thing myself, and it wasn't really a big piece on IT, was it?
No, and the result of that paper in 2002 was the setting up of a virtual ward at Croydon PCT. Yeah. And they called it a virtual ward for a very clear reason. It was modelled on ward rounds. So it wasn't modelled on care delivery. It was modelled on critical decision making. And it goes back to Alison's point about the workforce. All the research, and there have been evaluations in Canada, Holland, Germany, as well as the UK, that say actually the critical point is having a highly skilled multidisciplinary team in the same way that you might a hospital ward round.
Sorry, just let me stop you there, because I just want to say to John, I mean, this is an important point, John. It's about the decision making, not the care delivery, which are two separate things. So one of our top tips will be not to confuse the two. Yeah.
Absolutely. And obviously you need the care delivery as well, but actually, one of the research evaluations is clear that this is separate from hospital at home.
Yes.
So you can do hospital at home without having a virtual ward with a multidisciplinary team making decisions.
Yes.
So what's a little bit concerning about the NHS model that's currently being put out is that we don't know what the workforce model is. We certainly know the report that came out in December from NHS England said it was going to be staffed by band 4s.
Yeah, can I stop you there, Elaine? Because I want to sort of deal with the workforce as a separate segment, if I may, because I know Alison has done some work in this area as well. I mean, so what we got thus far, and feel free to contradict me if I haven't got this right. What we got thus far is this is not a one-size-fits-all thing that suits everybody. As many people as there are in the community, there are probably as many approaches that you will need. And it's I mean, if we were going to say, okay, technology, just look at the technology for a minute. If you were going to try and stop elderly, frail people going into hospital, then you would want to monitor certain things like fluid intake and infection or falls or what, that kind of stuff. But if you've got someone discharged post-COVID or even maybe pre-COVID, you've got pulse oximeters, you've got temperature, you've got a whole different load of stuff. So it's not it doesn't all sort of go down the same road. Steph, you're nodding there. Are you agreeing or disagreeing?
No, I agree. I agree with what you're saying.
I'm hoping you disagree.
No.
Yeah. Yeah, Alison, you usually disagree with me. Go on, disagree with me. Yeah.
Oh no, I don't disagree, and I don't think all these different models are a bad idea at all. I think people can stay at home is fantastic. But the concern is the workforce to me. So the fact that these different models are introduced without any workforce impact assessment, and then that workload ripples through the system, causes problems. So the thing that I'm currently getting the most messages about, and it's not just virtual wards, it's discharge to assess, it's some other services that are in the community, is that they're 8 to 8 services or 7-hour services. Someone's got to pick up the rest of the work. District nursing.
Yeah. Well, I mean, just to stop you there for a moment. I mean, okay, so you've got someone who's sort of tucked up nicely at home. They've got all the kit they need, and everybody's monitoring them. However it is we do it. Someone's sitting at home. I guess a nurse could monitor this from home. She doesn't have to be in a hospital because the technology, you could read it out anywhere. So suddenly she decides, okay, Mrs. Smith at 25 Acacia Avenue is looking a bit dicky and she needs some help. And it's like, make it an awkward time, like 8 o'clock in the evening. What do we do? Elaine Strachan-Hall, you've done this. I mean, what do you do?
Absolutely. And one of the critical success factors for us was actually having, we called it a care bureau, but access to a 24-hour service where we could actually get to someone, or we could get them to a hospital environment. So every service was set up with the in conjunction with the local NHS trust, so it was local. But I think that's where protocols and thinking through all the things that can go wrong is really critical, important. And as Alison said,
thinking through the protocol, protocols, John. That's another quite important thing. I mean, Alex, what have you got to have on standby here? I mean, you got to have the ability to take someone back into hospital or into hospital. That's called an ambulance service. You've got to have someone who can come out and make a decision. That's called community nursing. You've got to have someone monitoring this. So we know we've got ambulances, we've got community nursing. I know they're busy, but we've got them. The extra bit is the person sitting doing the monitoring.
Yeah.
And that's really got to be someone pretty senior and pretty have a good repertoire of the understanding of care. I mean, this doesn't look like a cheap model.
No, and I think you're absolutely right. And you do need somebody that can take a decision looking at data on a screen or talking to a patient on the end of the phone to take the right decision to either, call an ambulance or get somebody out to them, an on-call system, in fact.
Yeah.
The other thing that you need to consider, though, is before you get to this point, it's really about patient selection and making sure that the service that you're sending a patient to, the virtual ward you're sending them to, is the right service and it's the right time. And I think that sometimes is the problem, is that if people are discharged too early, or they're not going to cope. Not sort of socially, but not going to cope at home, that can cause problems. So you need somebody very experienced in assessing patients for the discharge onto the service.
Yes,
a very senior person.
Yes, and to do that, Gina Sargent has just put in the chat box, and Gina, hi, good evening. It's lovely that you're with us. Thank you for joining us. She says, I mean, it's a pretty obvious thing to say, but decent 4G laptops or mobile phones and access to the shared care record in real time.
Yeah.
Well, has anybody got anything to say on how we're going to access shared care records in real time? Discuss. Elaine, Maxwell.
I think that does already happen. I don't think we lack the capacity to do that.
Well, hang on a minute, because I mean, if you look at what's happening in the community, I went down and saw the Virgin Care system. This was before COVID now, obviously, but actually, I mean, they had a sort of access to Rio, which is what they were using in the community. They sort of had access to some kind of prescribing history, but it wasn't complete. They had no access to the hospital's EPR system.
So I think it's technically possible. It might not have happened in some areas, but that's not a technological problem. That's a interface between different software, all the things we've been talking about since 1985 on digitalizing the health service. And that's about culture.
But that's why it's so difficult.
But I'm not sure that actually that matters so much. All the research shows it's about having people with enough expertise and clinical judgment. I'm not actually sure that monitoring somebody's heart rate minute to minute is the most effective thing to do. And when you said about somebody sitting there looking at the monitoring, actually nurses do use monitors to support their professional judgment, but they don't use it instead of professional judgment.
No, I'm not, Elaine, I'm not suggesting that they do or they don't. What I'm saying is you have to have someone pretty senior and pretty experienced who's going to be able to do the monitoring. I mean, you can't have 30 people out there depending on technology and hoping that someone's monitoring if something goes wrong. Alison, you wanted to, can I just
come back on that point? So there has been a review of the COVID wards.
Sorry, there has
been a review of the COVID wards.
Yes.
That's been published.
And what does it say?
What it shows is that actually it is that ability to ask secondary questions of patients that's important. They did manage to get the data because they're using apps to bypass everything else. What they didn't do, there wasn't any data on outcomes or economy. So we don't actually know if this improves patient outcomes. What the data from the older model shows is it doesn't prevent emergency admissions, which is what you're talking about. It does prevent non-urgent admissions because you can put up services to keep people in the community. So there's no evidence this will stop emergency admissions because somebody deteriorates, even in the COVID wards.
I just want to go to Alison's because I don't want her to lose the thread. Go on.
No, it's really just following on that from that, Roy. So looking at that NHS England model, most of the care seems to be provided by Band 4 workers. So different sorts of Band 4 workers, I imagine, overseen by a non-specific Band 7 worker. So is that are those the kind of workers that can provide that kind of clinical acumen and expertise and make those decisions? And I think Elaine's point is really important about the outcomes because of the assessments that I've seen. So the ComFed article that you kindly sent me, the only important outcome seems to be saved bed days and not clinical outcomes. And I think that's quite a dark road to go down.
Okay, if you were going, okay, so
yeah.
So I'm sorry, your sound is slightly choppy. So if we were going to, I mean, look, I mean, let me put this in a sort of very blunt way. I mean, I'm sure it's much more finesse than this, but there is somebody in the Department of Health thinking, we got to keep these people out of hospital. We'll give them all whatever tech it is because it's cheaper and let somebody monitor it and we'll keep them at home. I mean, that's it. This is obviously what it is. It's second best to being in hospital, or is it better than being in hospital? Steph, what do you think?
I think I think some of it depends on patient choice and the acuity of the patient, whether it's okay to keep somebody at home and safe to keep them at home, I think is the critical thing. And then, as Alison and everybody else has said, that you've got the right workforce to look after them. That has to be the critical bit. So in my model, we don't have nurses or anybody else sat watching monitors. This is about the assessment of the patient and the decision making around that, as Elaine said, and knowing how many times a day we need to go in. I should also say that in Leeds, we also had an investment in this. So it wasn't done on the current workforce. There was additional investment to ensure that we had the right workforce.
Okay, tell us about that, Steph, because that's quite important. Just walk us through, briefly if you can, because we're halfway through our time already, but just kind of walk us through what it looks like where you did it.
Yeah, so it is run, it's a nurse-led model. So it's advanced clinical practitioners, district nurses working together to assess the patient needs. We have access to, on a daily basis, and there's a multidisciplinary team meeting with the hospital geriatrician. We have access to out-of-hours services with our district nursing teams, as well as our out-of-hours GP service. We have our integrated teams already have occupational therapists, physiotherapists, pharmacists within that. So it is really, as Elaine described, a hospital ward that's brought into the community, if you like. But we're really clear.
At what point, Steph, at what point do you say, there's some suit somewhere looking at the numbers and the finances, at what point do they say, this is all costing us a bloody fortune to keep people in? Why don't we put all these people together in one place? It's called a hospital, and we could look after them by just running down the corridor.
Well, I guess you could. I guess it goes back to Elaine's other point. It's about outcomes, isn't it? And not just, it's about clinical outcomes and getting those right for patients. So some patients, we have had patients die on our virtual ward, and I'm saying that because that was the right thing for that patient. So it was right that they transitioned onto an end-of-life pathway.
So that was an end-of-life pathway, which we're quite used to doing, aren't we?
So but they might have started with something more acute, and it's ended up like that because of the right decision making throughout that process. But that was the right outcome for the patient, because that was, you know, they wanted to die at home, we kept them at home, etc. So I think it's about the clinical outcomes, but I agree, it isn't, I don't believe this is a cheaper model at all.
No, I don't. Is it? And the end of life care are usually prescribing nurses, aren't they, as well? Often they are.
Yes, our district nurses and advanced practitioners will all be able to prescribe.
They'll all be prescribers. Yeah, exactly. Alex, did you want to come in?
I did, Roy, but it was really about the previous conversation around the technology. And,
we'll come back on that, yes.
Yeah, so the use of the technology, I find, when we're talking about benefits of it, also provides some benefits to patients. It provides a degree of reassurance to the patients because they can see what is being recorded, you know, on either a wearable piece of technology or what they're putting on their app. And so I think, you know, we've mentioned this to some degree on this call, but I think the patient experience, the patient choice, and the patients and how they progress and perform on these virtual wards is really an important factor. And I think we need to take that into account also.
Yes, Jean has also reminded us about people deconditioning in hospital, which is an important thing to say. But when you say, Alex, this is about patient choice, I mean, are we really going to say to someone, well, you can come into hospital and we'll look after you, or we'll look after you at home? What do you want to do? And I imagine a lot of people, little old men like me in their mid-70s who live on their own, might say, actually, I feel a lot safer if I was in hospital. Or are you just going to say, we don't need you to come into hospital, Mr. Lilley. We're going to give you an iPad and a thing you can put on your finger, and we're going to look after you at home. Won't that be better? And I'm going to sit there and say, well, yeah, I suppose. I mean, I don't see how people are going to get the choice in this. Elaine Maxwell, hang on. I've sparked something with Elaine Maxwell. Go on.
Yeah, so it's going back to the outcomes. So the original pilots were not about short-term outcomes. They weren't just about saving a bed day this week. They're about, originally they were with the frequent flyers. Remember that term, frequent flyers, turning up ED? It was about working with people on this transitional care. And I think the word transitional is really important. People who are going in and out of hospital need support to be able to manage their care in the community. And probably the most useful thing about virtual wards is helping them to get to a state where they can manage. So actually, the number of readmissions is a much more important outcome measure than bed days saved.
Right. So then we're in the territory of what used to be called, I don't know if it still is, step up and step down care.
Well, I think it's a bit more than that. I think it's actually a bit more than that.
Somebody wanted to come in. Was that Elaine Strachan-Hall?
It's not just, it isn't just about, it can be step up care, it can be step down care, but it's actually care in the home as well. So it is that interdisciplinary, the ability to have a service that's focused around that patient and that person. And I think for some people, absolutely, they'd say, I'd prefer to be in hospital, but other people say, absolutely, I'd prefer to be at home. How can I be safe at home? And our role as professionals has to be to lay those choices. And whilst there's sometimes where there is less choice because of availability currently, there is a difficulty of actual bed space. But I'd like to come back onto the issue you talked about, is actually, is it cheaper or not? In staffing, absolutely, the staffing is not a cheaper option, but there are other things about why hospitals are expensive. Hospitals as buildings are expensive, and where you expand that capacity by using the home environment, you're expanding a capacity that you're not paying for some things. So
right, well, let's just hang on a minute. Just John, if you could sort of make that point about the cost and all that, I think it's very important. But I mean, if we get into the actual, I don't really want to go down the arcane methods that the NHS uses to cost things. But I mean, you've got a fixed overhead in a hospital, and frankly, if you've got 100 beds or 102 beds, it doesn't make a lot of difference. But if you've got to set up an entirely different infrastructure to look after people in their own bed, then the cost per bed in that person's home would probably exceed the cost per head in a hospital.
I think I've not looked at the economics, and actually very few of the papers look at the economics, and I think that is going to be quite key. But beyond economics, it's the workforce that will be the biggest constraint in any environment. Yes. Because we know that we can put people in cars and get them to people's houses. It's a lot more difficult to actually find the people that have the experience, that's community orientated and really understands the clinical condition and the interprofessional working. That takes time to develop, as Steph, I'm sure.
Sure, you've got to create a team. Yes, Alex Evans.
Yeah, I was just going to say, related to the conversation about the health economics, I think there's one other metrics that's quite useful, and that's around patient flow. And so, looking at patients coming in, having elective surgery, and then going out, I think where a virtual ward can help is really in that scenario, and you can prepare a patient for, what their care is going to look like in terms of they'll be admitted, they'll have their surgery, and then on whatever day, dependent upon their clinical situation and dependent upon their personal situation, then they can move into a virtual ward, and that releases the bed for
the enhanced recovery program. I saw them at Epsom. They did a day case with a replacement knee. So I mean, for God's sake, a knee is a really complicated operation to do. So I mean, all that sort of stuff exists, and then of course the benefit of that is that the yield on the bed, which is what the finance department talk about, that's how many knees you can get through that bed, the yield goes up. But then, of course, you've got the situation, and I don't know if Steph or Elaine Maxwell can tell us about what the literature tells us, but you get into the situation then where, okay, you've got a certain number of people you're looking after in the community with whatever it is. You need to have a reservation of beds available if something goes wrong, because at the moment, I looked at the statistics for last month, we've got hospitals running at 93% occupancy. You haven't got a hope in hell of getting a bed.
No, and the literature is very clear that virtual wards do not stop emergency readmissions, because by definition, the people who are there, if they've got multiple long-term conditions, which are the group that's been studied the most, they are at risk, and sometimes they do need to be in hospital. So what it does do is reduce the non-urgent admissions and stops this going round of frequent flyers. But yes, there has to be some build in the capacity of acute hospitals for some of these people who will have to be readmitted to hospital because it's the right place for them to be.
Yeah. Right, Alison, hit us with the staffing thing, because I know you've looked at this.
Yeah, so the key for me is workforce impact assessments, really. I think we're seeing lots of new services, not only in the community, but in the acute sector, things like the elective recovery plan, and there's no workforce impact assessment at all. and these services have to be resourced. And the main issue is that they're going to the existing workforce to resource them. And this is what's happening in the community. That's why it surfaced for us. Also, the use of technology is causing fairly significant ripples through that workforce as well. So things like monitoring and remote medicines administration, things like that, are actually causing issues for the community nursing workforce in terms of making more work, not less work. It might be because they're drawing attention to things. It really needs to be researched properly, but it is a significant issue. Also, a lot of these services don't seem to be regulated. So the wearables technology industry and the various kind of virtual services that are offered don't really seem to have any kind of regulation around them. It's variable anyway. And we've seen some quite fairly unsatisfactory reports of services that have caused patient safety issues. And some of them are going to surface probably in coroners PFDs in the not too distant future. So,
well, if I could just interrupt you there. Kenny Gibson's made a very important point in the chat. He said any patient in the family who are party to any of the many virtual ward models will need trauma-informed approaches and strength-based interventions for safeguarding. Safeguarding aims to keep you updated and safeguarding. I mean, there's his website there that you can have a look at on safeguarding. But there is I mean, he's right, isn't it? There's a safeguarding issue here.
Yeah, I mean, there are lots that, generally, if you're working with vulnerable people, there are safeguarding issues. There are issues around the provision of care, so expert nursing care, not just domiciliary care. So it's a sort of much more complex thing. And I think that the fact that there are all these different models, and some seem to be, very effective and maybe others less so. Yeah. Just assuming that one model is going to then be able to be rolled out with no resources, I think is actually quite a risky place.
It worries me. I mean, it's pretty clear to me that the DH, because the DH is running the NHS at the moment, it's not NHS England, but I mean, the DH, have got the hots for this idea. And they're making plans that everybody's got to catch up with. Can I just I'm going to come to Steph Lawrence, but I just want to get a comment from Sharon White, who's put in the chat. Good evening, Sharon. Thank you for this. Good evening, all. I'm Sharon White, CEO of the School and Public Health Nurses Association, and she's cunningly put her website in there. Our workforce urgently redesigned during COVID to deliver services digitally to children, young people and families. We're now trying to better understand the best fit moving forward, and there are early indications that our clients would benefit from a hybrid model, including face-to-face, virtual wards or digital surgeries. They all may have a place. Here to learn. Thank you. Well, we're all here to learn, but that's a very interesting point that you've made there. Thank you for that, Sharon. So, Steph, okay, where are we now? Where's your thinking at the moment on this?
Well, I don't think it's changed. I think we still got to come back to that workforce issue, as Alison says, and it will.
Yes. Well, let me ask you a question. Can we've got a shortage of God knows how many nurses. I mean, it always makes me laugh when people say we've got a shortage of 40,000 nurses. Actually, that's only because people have counted 40,000 adverts for nurses. One advert might disguise the fact they're looking for 10 nurses. So we don't know we have no idea what the shortage of staff is in the NHS. It's a guess. So given the situation we're in with nurses, what's your punt on the staffing issue?
So, well, my belief is you can only run this if you've got the right number of staff at the right level to do it. So I don't.
But it's because we haven't that we're doing it.
Well, yes, I guess it is, but
I mean, we're not doing this because we got loads of staff and they got nothing to do. We're
someone's bright idea, Roy, isn't it? Someone's bright idea.
And that's the problem. We don't actually explicitly know why we're doing this.
Who said that? Oh, it's Elaine.
Yeah.
We don't actually know why we're doing this. We're all assuming that NHS has done this because they think they could got to.
Hang on, I've got to recover from that. That's the comment of the evening, isn't it? We don't know why we're doing this. That's brilliant, Elaine. Yeah, go on.
But we think it's probably driven from a concern about capacity of hospital beds. But after that, I'm really disappointed we haven't looked at the evidence. In response to a comment I've just seen coming up all the evidence is this does need to be multidisciplinary. So whoever put it up, it's not just about nurses. You need to work very closely with GP practices. The early studies were based around GP catchment areas. Somebody else has talked about pharmacists. Absolutely. You need a whole load of skilled professionals, OTs, physios, pharmacists, social workers, everybody involved, because as Steph and I have both said, the premise that's been researched is this is a hospital ward round in the community. But it's not, the danger is if we don't know why we're doing it and we're not following the evidence, we could end up with a very risky service, as Alison's already alluded to.
Steph, Steph, you've been prayed in aid of the argument here. You better say something.
Yeah, so I think the important thing is that if we haven't got the staffing, then we can't have the beds in the community, just like you wouldn't be able to have the beds in a hospital. And I can give an example of that. So over Christmas and New Year, we monitor on a daily, twice daily basis how busy the virtual ward is and what's needed. And we did pause admissions onto the virtual ward because it wasn't safe to take in.
Really, just hang on, stop. Say that again. Over Christmas.
Yes.
The virtual wards were full.
No. So I'm talking about the virtual ward in Leeds, and I'm talking about in a 48-hour period, we paused admissions to the virtual ward to allow us to care safely for the patients that we had. And that for me is the first and foremost priority. If you've got either too many patients, the acuity and complexity of those patients is too great, or you haven't got the staff, then it isn't safe to do. And
yes, you're right. I mean, Alison's going to kill me for saying this, but I mean, if you've got a ward and you're short of staff, it's still sort of safe. I mean, she's going to kill me for saying that. But if you got virtual, wait, let me dig myself out. Let me dig myself out the hole.
It's finite, Roy. It's not safe, but it's finite because you've got X number
you know
of
what I mean. But if you've got people in the community and you don't have enough staff, it's bloody dangerous. That's the point I was going to make.
But I think actually the staffing issue is the issue wherever. And I do think we need to look at both virtual wards and hospital wards. We need to look at what's best for the patients and where's the best to provide that both in outcomes, because surely we don't have enough staff to manage it sometimes in the community. We don't have enough staff in the hospital. Neither is the right answer. One is not the answer to the other. It's actually what's best for patients. And I absolutely with Elaine on, we need to make sure that the evidence, we build the evidence as we go, and we look at what the outcomes are. And those are outcomes both clinically, but also from an experience, but also then what's the most effective and efficient ways of managing services when we have workforce shortfalls. That's the absolute nub. And Crystal Oldman, Crystal, is nice to see you. She runs, of course, QI, Queen's Nurses. Why don't we think about strengthening existing district nursing teams? Well, we know their capability. They already work in multidisciplinary teams in the community. They're brilliant networks and they know their communities. Well, exactly. I mean, this is really the nub of the point, isn't it? The reason, Crystal, that we're not doing that, and if you want to join the conversation, light your screen up and turn your microphone on. The reason we're not doing that is that we haven't got enough district nurses. We've got no prospect of getting enough district nurses in time to deal with the tsunami of problems that we've got coming down the track. So this is I mean, would it be wrong to say this is like this is going to end up a poor service for poor people?
Could I respond, Roy? And
hello, Crystal. Good evening. It's very nice to see you. Yes.
Can I just respond to that and say that the point that I was making was that if we need nurses and we need registered nurses and others that are unregulated supporting them as they do in district nursing teams, why aren't we thinking about strengthening the services that we already have? So if you're saying we can't have more district nurses, well, we can have more nurses that work in the district nursing team. So what I'm saying is about strengthening what we already have, that we know a well-networked local district nursing team, and strengthening them, not layering on a new kind of service.
I get the point, but Alison Leary will tell us why we can't do that.
No, I agree, actually. I've watched workforce policy for a long time now, Roy, and
Yeah, I know.
And a new idea, a shiny new idea, will usurp tried and tested idea every time.
Yes.
Yeah, I mean, yeah.
I mean, that brings us back to earth, doesn't it? Elaine, Elaine Maxwell wanted to join in.
So radically, as I am a nurse, I just want to say this isn't all about nurses. So there are lots of other professions involved. But I would also say that, yes, there is an absolute shortage of staff. And yes, we will have to use new kinds of workers. The question is not having them, it's how they're supervised. And Alice and I could go off on another 2 hours now about nursing associates, but we won't. But the important thing is, if there aren't enough nurses, doctors, physios, pharmacists, we will have to use other people. But that will mean we all have to work differently because they have to be supervised more intensively. And that is my concern about the paper that came out from NHS London before Christmas. They're going to have all these band 4s with almost no supervision, which isn't fair to the staff coming in. What a way to put people off working in the NHS. And it's not fair on the patients, and it's not fair on the person left doing the supervising.
No, and I think the other thing that we haven't sort of, Elaine Strachan-Hall, I'll come to you in a second. The other thing that we haven't sort of mentioned is that I mean, Elaine Maxwell was right when she said, you know, this isn't one size fits all. There'll be different wards for different people who've got different needs and what have you. But of course, a lot of them will be elderly, and a lot of them will be having a care package from social services. So we've got to. There's an assumption here somewhere that social services fit in with all this, and I'm not really sure how that fits. Sorry, Elaine Strachan-Hall, you wanted to come back in.
Yeah, I was going to make the point that one of the critical success factors, the things that we found made it work or not, was the leadership, and that leadership at a senior level, which plays into what Elaine's saying about supervision. Absolutely, I can see that nursing associates have much to offer in this space, but they also, the role of the registered nurse to assess and evaluate is the critical skills, as would be a physio or another therapist. That assessment and evaluation is what I see makes this work and actually manages the safety. And so that does have to be played into the workforce, and those skills can't be replicated.
No, you're right. Gail Pasquale, she says health and wellbeing coordinators supervised and mentored by therapists working Gloucestershire. So, you know,
so definitely a mixed model works. It's that supervision and the level of understanding about assessment and evaluation, which is where that's what the professional qualification equips people to be able to do. Yeah, and Gina Sarton's come back. She said our RSWs work in a similar way, Gail, band 3 and 4s under supervision of a strong multidisciplinary team clinical leadership. You know, you've got to have somebody knowing what they're doing to make this safe, haven't you?
Well, it comes back to the whole point. The original model was about multidisciplinary decision making, which has to be made by expert professionals. And that is different from the care delivery. I think the argument, we're conflating delivery of care, whether it's hospital at home, domiciliary care or whatever, with the decision making, which was always the core, and in all the literature is the core of how you can manage higher risk people at home.
Yeah, that's a really important point. Alison, if this is going to be sort of set up right, you know, whatever that means, and I know there's like a huge variation in the clients and patients who will be using this, but if it's set up right, what would good look like?
I think good is going to look well resourced, so in terms of staffing, and also risk managed. So that's one of the key things. My own personal experience of these services, that risk wasn't managed at all. Yeah, it was about giving people technology who weren't able to interpret what the technology was telling them, and then ended up in very risky situations. Yeah. So,
Steph, you've run these services. How did you approach the risk management?
So the same as we would in any community service. It's about the assessment. Making sure that we've got the right level of staff. And I think, you know, Elaine's point about non-registered staff is really, really important, because you can only delegate work through an accountability structure, because the registered person remains accountable for that work. So it's critical we get that right.
Yeah. What about you, Elaine Strachan-Hall? You've done this as well. What was your approach to the risk?
It was a really sound. You had to assess risk and think about everything that goes wrong, that could go wrong, and think about how you're going to manage those situations. And as Steph said, that's really core to any NHS business. It's core to the way you run any service. But risk management and thinking that through, but also learning from anything that is new. You might call them an edge case in technology. Anything that's new. What can we learn from this, and how do we make it safer?
Yeah. Would you say that then, you know, the department are looking for 500 per what we used to call a district general hospital. The definition of the patients who will be suitable for consideration is important. Alex Evans, you're nodding.
I am, yeah. I think, as Steph said, the acuity of the patient is really, really important, as is the assessment. I think for me, though, the key to it all is running this service like a ward. You know, it's called a virtual ward, and the leadership, the skill mix, the multidisciplinary team involved is really, really pivotal to making this a success.
Yeah. Paul Rylance is with us tonight as well. Good evening, Paul. Nice to see you. Okay, look, we've got 4 minutes left. I have to finish on time. Look, I think I've had a summary anyway of the questions in the chat box. If anybody's got any massive burning question they want to ask, then now's the time to do it. But I'm going to start, I think, if I may, with Steph Lawrence and say, you know, give us well, you've done this, you know, give us a kind of upsum in 30 seconds of really what we should be looking out for if we're going to do this on a national basis. And you know, I mean, what happens with all these initiatives, they're started by enthusiasts, they're made to work by people who know what they're doing, and then suddenly the department says we're going to scale this up and we're going to do it everywhere, and everybody panics. You know, where are we? You know, what is your parting shot to us all on this?
So I would agree with what Crystal said earlier. Let's not make shiny bright. Let's enhance what we've already got. And for me, then it's about the right patients being cared for by the right level of staff at the right time.
Yeah, but we come back to the 3 rights, isn't it? Mm-hmm. And picking your patients is an important thing to make this a success. But, you know, if it's going to work, if it's robust enough, then you're going to have to deal with patients. And you know, it's got to work for everybody, not just for some, because you can see what's going to happen. This is going to become national policy. Let's go to Elaine Strachan-Hall. Final word from you, Elaine.
Thanks. I would start with a system approach. So what do we really need for the patients in our area? And I start from that perspective. So that moves us away from trying to meet a national determinant of so many virtual beds. It thinks about actually where are the best placed pet care for the people in our community? Is that in hospital? How much of it is in a virtual ward? And what type of patients might we be doing that?
Yeah, it's the same message all the time, isn't it? Pick your patients. Alex Evans.
So I would just say the technology is important, but it's not the only thing that's important in making a virtual ward a success.
But unfortunately, I think that this is coming from the desk of people who think that technology is going to solve all our problems. Elaine, Maxwell, you had the classic, phrase, "Why are we doing this?" I don't know if you can cap that, top it if you can.
Yeah, so I think anybody setting up a service should be really clear why they're doing this. Look at the research evidence, of which there is quite a lot going back to 2006. This isn't a shiny new thing. It's something we do in ebbs and flows. But for me, there's very clear evidence that different types of patients need a different service.
Yeah, that's not one size fits all. And Alison, I know what you're going to tell us. It's all about the people, the staff.
Yeah, it is all about the people. You've got to be able to resource it. So essentially, it doesn't matter if it's virtual wards or any other big shiny new thing that you're rolling out, particularly nationally. Do a workforce impact assessment and understand what the situation is in terms of the workforce, because the worst thing is to actually roll out something that's going to make people leave.
Yeah, I can see that. Listen, I don't know where the hour's gone. It's been such an interesting time. Thank you so much, ladies. It's really good. I still don't know whether I'm for it or against it. Anyway, let's see. Now, I can just tell you, John has been faithfully trying to keep a record of the salient points. We will be distilling it into a sort of one-sided piece of A4, 10 key points to think about. And I think we'll hope to get that out via the membership, I suppose, through your weekly mailing, John. Anyway, there we are, 6 o'clock, over to you.
Well, we won't be doing it onto a single piece of A4 because, Roy, you did such a good job. You were supposed to find 10 important things about virtual wards, and I've got 28 on my list. So, you know, where does that take us? My huge thanks to everybody involved this evening. Our panel, Elaine Maxwell, Alex Evans, Elaine Strachan-Hall, Alison Leary, Steph Lawrence, Roy, thank you. And thank you, all of you, for tuning in this evening as well. We have made a recording of this. We will make that available with a 28-point synopsis, but still a synopsis. And I don't think this is the last time that we'll be returning to this theme, actually.
No.
I think it'll be, it's provoked all kinds of further questions, I think, around the whole advent of digital technology. And if there is a single motto for the entire evening, it's Elaine Maxwell's, why are we doing this? So before anybody in government or in the senior echelons of the NHS and social care starts trying to foist new ideas and initiatives on the rest of us, the first question that the rest of us should ask, unashamedly, is we look them in the eye and say, why are we doing this?
It's the Elaine Maxwell question.
And it will be known as the Elaine Maxwell question. There we are.
It's fun. This is one of the best sessions we've had for a long time. Thank you so much.
Thank you very much, everybody. Really appreciate it. Just quick notes for your diary. Next Power Hour is Thursday the 24th on patient communications. Another Power Hour then on poetry, which is the 2nd of March. And a really interesting one, how to write an effective business case, on the 8th of March. And another one on critical incident reporting on the 9th of March. So as you can see, there is loads to go on. Those of you that paid tonight, I think it was 10 quid plus your £2 VAT. Don't worry, if you join the IHSCM, and by golly you should, by the end of this month, we will give you your money back and you get a super duper discount deal. It's just extraordinary. Get involved, ihscm.org.uk, and get enrolled. Thank you very much, everybody. It's been fantastic. That's it for this evening. Bye-bye.
Thank you all very much. Thank you. Thank you.